Good day, my dear undergraduate and emerging postgraduate students. I welcome you to this important class with a case history. This is not an assembled case, but an actuality that many a hospital sees. A 28-year-old male of African origin came to the medicine OP with complaints of breathlessness on exertion. On examination, he was found to be mildly jaundiced with respiratory bronchi. He was also found to be having a scar on his left leg. When asked, he disclosed a history of recurrent ulcer at that spot. So what is your diagnosis, blood picture, pathogenesis, etc.? That is a conventional mode of questioning. But then I would like you people to create your own permutation combination of multiple choice questions. So this is the leg ulcer I have been talking about. These are the keywords. Always keywords we should look for. Ulcer, African, jaundice. So this class is meant for all MBBS students, and the diagnosis is sickle cell anemia. The subjects involved are medicine and pathology. As is your pathology, so is your medicine. And R.A.T.S shall take us to what next. These are the subheadings that we people should look for. The distribution, the structure, the syndromes associated, the trait, pathophysiology and manifestation, crisis, diagnostic test, hemoglobin electrophoresis, other sickling symptoms. This is all the more important for the MCQ attending students because any of these can be asked as a question as such. I hope that you people are able to recognize part of Asia, Africa, and then the Mediterranean Sea, the countries to the north of it. So you find in these regions, malaria is more common, falciparum malaria particularly. And this is supposed to be having a close association with sickle cell anemia. Secondly, this map shows us the distribution of hemoglobin S. Various countries, including part of the Mediterranean and a good part of India is also. Africa, of course, as I had given in the history. So these are the countries, African, Mediterranean, and USA and India. In India, the states such as Orissa, Andhra Pradesh, Madhya Pradesh, Maharashtra, Bihar, Nilgiris. This will be the typical history that is given. Off track will be Nilgiris in Tamil Nadu. But strangely, we find typical history in such places and the diagnosis is sickle cell anemia. High in cases of areas endemic for falciparum malaria. There are two types of it. One is a sickle cell trait and another sickle cell anemia. And by definition, it is a hemolytic anemia. That is why you have got jaundice. Hereditary in nature with the production of hemoglobin S. Sometimes it is not fully manifest. We call it a trait. When it is fully manifest, it is an anemia. It is due to the precipitation of hemoglobin S, which forms a crescentic shape or a hammock shape. Hammock is a kind of a knife that is used for harvesting. See, there is a substitution of valine for glutamic acid in the 6th position of the beta chain. As a result of which, you find normally the hemoglobin S is quite soluble, but in this case, the beads of hemoglobin S, they become rigid and they form a chain. Actually, because of this, the RBC will get elongated and curvilinear. That is why you get the sickle shape as such. This happens in deoxygenation. So it is a normal RBC and this will be the sickled RBC. Initially, there is a reversible sickling, but later on can go in for irreversible sickling, resulting in vaso-occlusion and the crisis. Low oxygen tension precipitates it. As I told you, sickle cell anemia, it can be from both the parents. Sickle cell trait, one has a hemoglobin S, whereas the other is not. Sickle cell disease, on the contrary, is one gene for hemoglobin S and another for a normal or an abnormal hemoglobin. This, incidentally, is an X-ray of a skull wherein I am finding multiple hairs growing in the skull. This is called what we shall see. The electron microscopy will be showing bundles of elongated fibers which are getting spirally arranged. And these filaments are made up of hemoglobin beads and they get precipitated during deoxygenation. And this is the change and this is the crescent that is being formed. They are being removed by hemolysis. That is why the patient develops an anemia. There are other classical clinical manifestations which you people should remember. But all of them, whenever there is a sickle cell, you find that there is an increase of the viscosity. The blood becomes tenacious, like honey. It is not able to flow freely. As a result of which, there can be obstruction. There can be a failure in the increase in the ESR. One condition. So what happens is there can be obstruction, a stroke, there can be a retinopathy, congestive cardiac failure. In fact, in whatever organ you think of, spleen, lung, kidney, etc. Extremities, there can be vasoocclusion and ulceration. Sometimes there can be bone marrow hyperplasia or even hypoplasia. And also there can be crisis within the bone. It manifests only after 3 months because the hemoglobin F is protective until that period. There is a decrease in the height and weight, a failure to thrive. Jaundice is seen. Spleen is enlarged because of the activity, but later on it undergoes multiple infarcts and autosplenectomy. Priapism is the erection of the penis due to decreased amount of venous drainage. Quite painful. So this is a crew-cut appearance that can be given as a history for us or at least the undergraduates. What happens is there are the two tables of the skull, the inner and the outer tables, within which you have got the marrow. The marrow usually is not very active, but in conditions like hemolytic anemia, the tables get separated and it is being filled with the erythropoiesis. On the contrary, you find new bone formation can be seen. These appear as spicules producing a hair on end appearance. The factors that precipitate sickling can be hypoxia, acidosis, dehydration, and an increased amount of mean corpuscular hemoglobin concentration. This can be an incidental finding. Factors against can be increase in the hemoglobin F. That is why you do not have it until 3 months. Hydroxyurea is supposed to produce increased hemoglobin F. Therefore, it is protective against sickle cell anemia. So this is a normal blood picture. You find that the RBC, this is an RBC over here, which is usually normocytic, normochromic. But some cells can become sickle shaped. So they are curvilinear. Initially, there is a kind of reversible sickling. Whenever there is stasis, there will be a sickling. When it comes to a more open area, there is the reversal to the normal one. It is called reversible sickling. But later on, you find that the hemoglobin S becomes rigid. It is called as irreversible sickling, as a result of which you find that the lifespan can be reduced to as low as 2 days. Retic count is increased 10 to 20%. Polychromatic cells, that is the reticulocytes in the peripheral smear, can be seen. Target cells are specific, particularly when there is going to be a combination of sickle cell anemia and thalassemia. Look at this one. All the features you people can see. Sickle cell, obvious. Normocytic, normochromic. These violetish cells are the reticulocytes of the polychromatic cells. So these things, let us see. Serum bilirubin is increased because the patient is jaundice. There is a hemolytic jaundice. So this is a beautiful diagram from Robbins that gives an entire summary of sickle cell anemia. So there is a point mutation valent for glutamic acid. And you find because of that hemoglobin S is getting precipitated. The RBCs appear normal, but when there is going to be stasis, they become reversibly sickle. Later on, they become irreversibly sickle, particularly when they are passing through narrow passages such as the splenic sinusoids. The stasis can lead to infarcts. At the same time, you find that the phagocytic cells, devour the RBCs, leading to hemolysis. This can also occur in other structures, but bone will be important because the bone cannot expand. As a result of which, there can be occlusion, there can be pain, there can be necrosis. So this will be important. Also, some mediators of inflammation can be released because of it. And infarction can occur in various other organs, including the lung. Please remember that. And there can be a crisis also. Normally it goes on, but sometimes you find that there is a sudden downfall in the patient's condition. So there's an RBC, there is a deoxygenation, there is a production of sickle cells, which can lead to occlusion. This is called a vaso-occlusive crisis, which can result in ischemia. So there is an ischemia, there is a necrosis. So ischemic crisis. Hemolysis, when more and more of the RBCs are getting destroyed. So it is called as a hemolytic crisis. At the same time, you find bone marrow starts producing, but it is not able to do so at one time. It is called an aplastic crisis. Parvovirus can get precipitated by means of this. And Epstein-Barr virus is also implicated in the hemolytic crisis. Sequestration crisis, it can happen in any of the organs where there is a stasis. The bones particularly, you find that there can be the carpal tunnel-like syndrome that is there. Please do remember it. And then these are all the other features. There can be cholelithiasis, there can be the dysfunction of the endothelial cells. So this is an important diagram per se. It is called the fish vertebrae. It is not necessarily seen in sickle cell anemia. Some books on the MCQs will be giving this as the fish vertebrae seen in sickle cell anemia. But it can be seen in a number of conditions thanks to Willie Onley library. Osteoporosis, osteomalacia, hyperparathyroidism, Paget's disease, sickle cell anemia, multiple myeloma, SLE. So please do remember this is the reference for it. The crisis we have already mentioned. More important will be the hand-foot syndrome because of dactylitis, destruction of the metacarpals and the metatarsals. Bone and joint crisis can be there. Abdominal because of infarction, mesentery. CNS crisis because of hypoxia. Pulmonary, tachypnea and chest pain. Hematology, there can be aplastic crisis, hemolytic crisis. Spleen, there can be sequestration. Infection, fulminant infection, and can be because of Staphylococcus, Shiga, etc. The differential diagnosis should be hereditary spherocytosis. Clinically, both these conditions can produce cholelithiasis. There can be leg ulcers, there will be jaundice. My references will be Robbins, Davidson, one page, the book that I have authored, R.A.T.S, my channel, Tejinder Singh, an important contributor for hematology. The other complications can be cholelithiasis, autosplenectomy, leg ulcers, jaundice, ischemia, and there can be renal infarcts also, a classical leg ulcer. The investigations can be, one is the slide test or the sickling test. A drop of anticoagulated blood is kept on a slide and it is surrounded by Vaseline, a cover slip placed. The oxygen is utilized, it undergoes sickling, RBCs. There are two types of reduction tests called as sodium metabisulfite and a sodium dithionate reduction test. Because of that, there can be a precipitate which can be measured. Hemoglobin F estimation because it is inversely proportional to hemoglobin S. Chorionic villus biopsy for any of the replacement, valent for glutamic acid. High performance liquid chromatography is an important test. But more important to me will be the hemoglobin electrophoresis. By electrophoresis, you find the different particles which are otherwise similar get separated. It can be proteins or it can be hemoglobin, etc. So the hemoglobin S and A are getting separated. This will be even more meaningful. So it is a train journey. And we see how we travel in a train. There are two types of electrophoresis, agar gel and cellulose acetate electrophoresis. B2, that is A2 hemoglobin. A2, get into a train and we say CO to our friends, CEU. And the train moves with a rhythmic movement. SDG, SDG, SDG. It goes to the fag end of the journey. And we get down at the station called parts and go home. Each one of these are hemoglobins. A2, C, E, everything. And you find that hemoglobin, yes, it gets separated by this method. Therefore, it is a definite diagnostic method. So peripheral smear, all the other clinical findings, electrophoresis, and the reduction test can be done for the confirmation of sickle cell anemia. See you in what next.